All right, this is chapter, let's see, 16 of the ATI book. It's sedative hypnotic medications, and really we're going to kind of, well, we're going to talk about sedation and sleep-inducing medications. We're also going to get into a little bit into anesthetics. So these are the drugs and the categories that we're going to go through. So we'll just go through them. You've seen this slide before. So this was part of the anxiety slide set, and where we define CNS depression, which is a lowering of the activity of the central nervous system. Whereas there we were more concerned with anxiolytics. Here we're more concerned with sedatives and hypnotics. So sedatives, the ability to sedate or relax a patient. Hypnotics, their ability to induce sleep. So that's kind of what we're kind of moving into that realm. So we're going to see some of the same, actually some of the same drugs in addition to drug classes, but we're going to see some new ones too. So most CNS depressants can cause physical and psychological dependence. That's always a big deal, is addiction when it comes to especially like the benzodiazepines and even propofol. But okay, so may cause respiratory depression. We know that. That's kind of a big deal. Memory impairment, amnesia, confusion, over sedation, can't wake up the next morning. So that can be a problem. Okay, so the benzos. We've talked about the benzos multiple times. So midazolam, diazepam, and lorazepam are the prototype drugs listed in the book. Mechanism of action, we've seen that. It binds that benzodiazepine receptor subtype of the part of the GABA receptor, and it causes GABA to more GABA, or it causes it to move in more frequently, open more frequently, which causes more chloride to move into the cell, which hyperpolarizes everything. And by hyperpolarized, that means that it makes it really negative and really lazy, and it doesn't want to fire. So that's what benzos do. They inhibit firing of neurotransmitters. So primary therapeutic use, induction of anesthesia. So it's one of the drugs, and especially a general anesthetic is going to be a combination of a number of different drugs, and we're going to talk about that. And then what we've seen, anxiety disorders, seizure disorders, insomnia, muscle spasms, we just learned about that as well, and then alcohol withdrawal. So these keep showing up. Adverse effects, CNS depression, paradoxical response. Remember, we see that especially with in the elderly. And then maybe some nausea, vomiting, anorexia, physical dependence, we mentioned that, and acute toxicity, which is why a lot of times these are people can overdose on these, and people can die from that. The non-benzodiazepine CNS depressants. So this one is, we're talking now about sleep. So we're talking about a hypnotic. And this is one that a lot of people have heard about. It's not a benzodiazepine. It binds to the GABA A receptor, but it does it first of all a little bit differently, and it binds to different receptors somehow. I don't know exactly why, but it binds to different receptors in the brain, and has a different effect, slightly different effect than the benzodiazepines. But this is zolpidem or Ambien, and a lot of us have heard of Ambien as a sleep-inducing drug. And it's interesting because it still binds to the GABA A receptor, has higher binding to brain GABA A receptors, preserves sleep stage 3. So that's just a study that's been done when they looked at people who were taking this. They were in deep sleep longer, which is generally good. Minor effects of REM sleep, which a lot of hypnotics don't have that effect. It's less effective as an anxiolytic, anticonvulsant, or muscle relaxant, which is what's interesting and how it's different from a benzo, because it doesn't. You can't just take Ambien or zolpidem as an anxiolytic. It's not really recommended for that. So its primary use is as a hypnotic. Adverse effects: mild nausea, dizziness, diarrhea, and daytime drowsiness can occur. And the really big problems with zolpidem is the amnesia and sleepwalking. People do all kinds of crazy stuff. There are a lot of reports on things that people do. Actually, there's an article down here about some of the weird stuff that people have done on zolpidem. But eating while sleeping, then I have here, or driving, cleaning, murdering. So there have been people who have gotten in cars and run over people and then woken up in jail when they were on Zolpidem. So some really crazy stories. But I would say if it for the most part, it's obviously okay. Otherwise, it would have been pulled. And some people find it very helpful. So patients should take it at bedtime and ensure that they have a full 8 hours available to them to sleep, because they probably aren't going to be able to get up before that. So that's a hypnotic, the sleep-inducing drug. Here's another sleep-inducing drug. In the United States, this is actually available over the counter. It's not in Europe and other countries. But it's a melatonin agonist. And a lot of us have heard of melatonin, and melatonin is part of our circadian rhythm. So we have this internal clock that kind of tells us when it's time to go to sleep and when it's time to wake up. And melatonin is part of that. And the pineal gland in particular is part of that. And the pineal gland releases melatonin, which especially during low light times. So this is really kind of tightly tied to light coming into our eyes. There's the, if you know your anatomy at all, you have the optic nerve and the optic chiasm, and then right below, above that is the suprachiasmatic nucleus, which is detecting the light activation. It's mostly blue light, and that's going to cause melatonin release when low light enters the eye. Especially blue spectrum light, when that goes down. That's why on your cell phone, when you have the late night setting, it'll turn it to more of a red tone and get rid of that blue, and that's one of the relationships there. But anyway, melatonin is supposed to induce sleep. So and a lot of people say that it works. The effectiveness, some people say it, I mean, they've done some studies and it shows that people fall asleep maybe 12 minutes earlier and sleep 8 minutes longer. So it depends on the study you're looking at, but some people say it really helps them. So there you go. The prototype drug is Ramelteon, from melatonin. And the mechanism of action, it's an agonist, so it activates melatonin receptors. And the primary therapeutic use is to manage insomnia. So adverse effects, sleepiness, dizziness, fatigue, that shouldn't be any surprise there, because that's also kind of the therapeutic effect. You want to sleep. However, it can have some hormonal effects. The hormonal effects, even though, and these hormonal effects that are listed are amenorrhea, decreased libido, infertility, galactorrhea, caused by increased levels of prolactin. Okay, so, and I have here that this is a cascade effect. So hormonal effects in general are just because it seems to be that melatonin is a hormone, and so when one hormone is released, it may have an effect on others. And if you give the melatonin, it's usually in a pretty high concentration that it's provided. It can have an effect on other hormones, and in fact, evidence shows that long-term use can reduce the endogenous production. If you take melatonin every night, then at some point your pineal gland is just going to say, okay, it looks like we're not needed. And so it will stop producing as much. So it's almost like a not an addiction, but a tolerance type of effect that can happen with it. All right, anesthesia. So we talked about sleep-inducing sedatives and sleep-inducing hypnotics. And now we're going to kind of move into this world of anesthesia. So we kind of need to define that, even though we kind of have an idea of what anesthesia is. But it's a temporary state consisting of analgesia, which is loss of pain or no sensation of pain, amnesia, so memory, loss of consciousness, inhibition of sensory and autonomic reflexes, and skeletal muscle relaxation. So that's what we're looking for with anesthesia. And it usually takes several drugs to get in there, which is what we're going to talk about sort of here. So general anesthesia is suppression of activity in the central nervous system, resulting in unconscious and total lack of sensation. So this is an unconscious you're out kind of anesthesia. Dissociative anesthesia might be, where you see some people that are maybe getting nitrous or something, where the communication between the central, between the brain, the peripheral nervous system, there may not be a complete loss of consciousness, but there is definitely something going on there. And so it's defined as a suppression of communication between the brain and the peripheral nervous system. And then there's regional or local anesthesia. We're not talking about that here, but that's where it's just suppression of nerve impulses in an area of the body. So the drugs that we're talking about are IV anesthetics, so intravenous anesthetics. The mechanism of action should sound a little bit familiar for most of these. So anesthetics depress neuronal activity through three major mechanisms. So they can enhance inhibitory neurons. We've seen that before. So activation of GABA A receptors. Okay, so those are our GABA receptors that allow chloride into the cell that we've been talking about. So that there can be agonists that do that, which is what propofol, the drug propofol, does. Positive allosteric modulation. These are our barbiturates. So pentobarbital is our prototype, and then the benzodiazepine, midazolam, diazepam, lorazepam are the prototypes for those. Okay, and then there are opioids, and these are going to also enhance inhibition. So opioids, fentanyl, which is a synthetic, and it's a high potency synthetic drug, which is why so many people die from fentanyl overdose, because it is a potent drug. But a lot of times it's mixed with other things, or people don't know that's what they're taking and they take too much. But anyway, we're not getting into the details of the opioid receptors, the mu receptor, kappa, those kinds of things. But so we're just going to say for now that it activates opioid receptors. And that's going to enhance that inhibition. It's going to cause pain, but it's also going to cause some CNS depression. So you can enhance the inhibition, so you're inhibiting more of the brain, that's the depression, or you can diminish the excitation. So we have excitatory neurotransmitter, glutamate. Glutamate is an excitatory neurotransmitter. One of those is the NMDA type. There's also AMPA, but in the case of ketamine, which is our prototype drug, it blocks these glutamate receptors, these specific NMDA type of glutamate receptors. Glutamate's excitatory. You block it, then that excitation goes away. So that's why it kind of falls under that category. And then there are some non-selective mechanisms. So inhaled anesthetics can cause membrane hyperpolarization via activation of potassium channels. I have that underlined, but I don't think we actually have a prototype drug that covers this mechanism. Okay, so if we look at the ones that we have, and I have this listed a few different ways. So used alone, combined with others, or as adjuncts to inhaled anesthetics. Even though we're not talking about inhaled anesthetics, things like halothane are examples of things that can be inhaled and can cause anesthesia. But we're talking here about IV anesthesia, and they can be used with other kinds of methods or mechanisms. So the main groups, the GABA A activators, those are barbiturates and benzos. So pentobarbital is commonly used for induction of anesthesia. Benzos are used as pre-anesthetic and as an adjunct to local anesthesia. Midazolam, so midazolam is listed here, and it's one of our prototypes. It's water soluble, so it's actually preferred for IV administration. Okay, the recovery from anesthesia can be slow with the GABA A activators, but there are antagonists, so GABA A antagonists like flumanazole, that can be used to speed up that recovery. Okay, NMDA glutamate receptor antagonists. Okay. So we had GABA A activators, that's activating inhibition. NMDA glutamate receptor antagonist is inhibiting excitation. Okay, and that's our example of ketamine. And then the high-dose opioids, high-potency fentanyl is preferred over morphine. And these are, so the high-dose opioids are used in combination with benzodiazepines Also used for epidural routes of administration. So there are opioids that can be injected in the epidural area of the lower spinal cord, spinal column, to cause localized. That's the epidural. So from that point down, directly at the spinal cord. Okay, so this is just kind of another way to look at this that has it kind of listed out here. So the ketamine, and these are the some of the side effects. Induces hallucinations. I think I have that listed individually on the next page as well. Let's see if there's anything here that kind of stands out. Midazolam, I know, used in balanced anesthesia and conscious sedation, provides cardiovascular stability. Propofol, most common, used as an induction and for maintenance of anesthesia, can cause hypotension. Yeah, so I think I have these things also, a lot of these listed here. So in general, IV anesthetic complications are respiratory and cardiovascular depression, okay, with a high risk for hypotension. Propofol, I believe, is the one that killed Prince or Michael Jackson or somebody, or maybe both. I don't know. Don't quote me on that. So respiratory cardiovascular depression with high risk for hypotension is generally what it is. Propofol has this interesting characteristic in that bacteria like to grow in it. So once it's opened, it has to be used within 6 hours because the propofol emulsion, it's an emulsion of the drug in a support solution, but that supports bacterial growth. So use open vials within 6 hours, monitor for signs of infection in the patient, such as fever, malaise, after surgery. Ketamine has psychological reactions. It's actually, I think, a street drug, which surprises me, but it's a street drug that can cause hallucinations and mental confusion. I guess people like that. Children less than 15 years of age and adults over 65 are at a higher risk for these psychological types of reactions. And that's, believe it or not, it for this section.